and welcome to Cardiac Sciences Grand Rounds, April 25th. Today's talk is being given by our own Jonathan Howlett. He is in charge of our heart function clinic and advanced heart failure program. Today, he is going to educate and entertain us with a talk on personalizing heart failure therapy in an impersonal world. So Jonathan, I'll turn it over to you.
Okay. Do I know how to run this? All right. So this is the necessary stuff. This is my speaker disclosures. Many of you have seen that before. And I've been known to have a coffee with just about anybody, even Dr. Kia Manesh. So keep that in mind when you hear this. I will be talking about off-label, absolutely. I was going to have a little bit of fun with this agenda and mix and match a little bit. I'm going to present a couple of cases just out of interest. Some of the details were changed, mainly to make points, but also, as they say, to protect the innocent. So there's three major parts. I'll start very, very briefly by starting with how I'm going to define personalized heart failure therapy. It turns out that there's no formal definition of this. It's really in the eye of the beholder. We'll talk about some of the things that I've noticed in my own practice and therefore have taken to be gospel that are necessary for good personalized therapy. That may not be your gospel, of course. And then we'll talk a little bit about what others have done and how it relates to what we are, particularly because we are now on an electronic medical record. So I'm going to use an example here. This is a polymorphism of a beta blocker receptor. And many of you probably are, well, I'm looking out here, many of you are clearly too young to remember this. But this has come up again and again, maybe the ACE-DD-I allele, so on and so forth, that have been associated with differential responses to certain drugs. The oncologists ran with this. In fact, this forms a large part of their new drug discovery in oncology, and we're way behind in cardiovascular disease. Probably because mechanistically we're just a little bit less sophisticated in learning why these drugs work, particularly in heart failure. But we see that certain drugs work less well according to a polymorphism, and this is a GLUT-val switch. Just one amino acid switch in the beta-1 receptor, and one of them associated with the wild types associated with a good response to a beta blocker, the others not. And there are many other examples of this throughout. And that's kind of the genetic model, but it's more than just the genetic model. And so what the genetic crowd believes, and this is really where the oncologists have ran with it, because they have fairly close association with genetic polymorphisms or certain genes that will predict response to therapy, is they make a primarily genetic description of what, and so they really look at it through that lens. But you can look at it through any lens, whether you look at their genetics, their phenotype, their physical characteristics, even social factors can come into personalization of medical therapy. So it has to do with all of these different aspects of a person's presentation and their situation, their characteristics. But here's what I'm going to use therefore. It's a little less sophisticated, but I think more useful, particularly in our business. And really it's dealing specifically with the person in front of you and using what works. And this is particularly true after you get past what I would call the routine aspects of heart failure. And if I could ever envision a future of heart failure care, it would be where the generalist, family doc, internist, etc., where they know what the routine treatments are for a certain type of heart failure, fairly same for all the different, fairly similar. But then after that, after you get through to that, then the personalization is taken care of by people with a lot of expertise and experience and knowledge in treatment of heart failure. And that's where people that are in this room come into play, because you're a fairly sophisticated audience, you know what you're doing, and you're dealing with complex issues. So that's how I'm going to describe personalized heart failure therapy. The trouble is getting to personalized heart failure therapy isn't, you don't start from scratch there. What I do is I try to overlay the routines. And in order to overlay the routines, there are certain situations like, and I'll use for the best example in heart failure is low ejection fraction heart failure, HFrEF, okay? Because we have cocktails of drugs that have been proven to work. This is the recipe, this is the chemotherapy, if you will, that works for all people or most people in that setting. And the trick is to get that on, because if you don't get that on, then you're not able to observe the presentation or the phenotype in front of you to make further decisions. Furthermore, some of them respond extraordinarily well to that and really don't need much else. So foundational therapy, or what you would call you would call it standard therapy, you call it quadruple therapy, whatever you want to term it, that needs to be in place. But there's more to it than that, because heart failure is about volume. And one of the things that we've done very, very poorly in the heart failure world is we've done a bad job of describing how to use diuretics. We just say, use the minimum required. Okay. I mean, that's like saying, use the minimum required discipline for your kids. How do you do that, right? I challenge anyone in the room to write an essay on how to do that for the rest of us. See how we'd like that. And it has to be done because it has to be done in this fashion, because everything is affected by everything else. It's all interrelated. So the degree of volume in a patient, we've gone full circle. We used to say, don't use these therapies until people are completely dried out and are euvolemic. And what we've come, many of us, and myself included, have come to realize that it's actually much easier to manage and titrate and introduce therapies when they're a little bit volume overloaded. It's much, much more difficult when they're dry. It's okay when they're euvolemic, but it's much more difficult when they're dry. And of course, determining that at the bedside can be imprecise, and so you end up making a lot of mistakes. That's why iterative treatment, multiple touch points, follow-up is essential to know. So because of this change in the attitude towards treatment of patients with volume loading, we've come to realize that the best place, not the worst place, as I was taught when I was your age, I was taught never to start these drugs in hospital, to wait until they're perfect before beginning them, and to wait a period of time. And all of those things were wrong. I'm even old enough, by the way, to remember when beta blockers were contraindicated. I'm pretty sure no one else in the room was old enough to remember that. But we were taught in medical school that beta blockers were contraindicated in heart failure. That's how old I am. Almost as old as the cost. Turns out that starting these medications in hospital, just like any other disease, means that they're more likely to be on it down the road. They're on higher doses when they're down the road. And we see that, and how many people here will get consults because the creatinine goes from 130 to 150 and then drugs are stopped? Happens all the time. Turns out that what you see on this slide, this is taken from a combination of the Paragon and Paradigm trials. So these are outpatient trials. The reason I'm using these slides is because it was very recently published. It has a new medication, sacubitril/valsartan in it, and because the slides are much, much nicer than the older data. But it shows the same thing for inpatients. Inpatients who are started on these GDMT therapies, and you're going to hear that word a lot, GDMT. GD is not a bad word. It starts with goal-directed, okay? Goal-directed medical therapy, GDMT. That's what we mean. We're talking about the big four foundational therapy. And when you start these drugs in the hospital, okay, if they have a change in their creatinine without a change in their volume status, or if their volume status doesn't worsen, they actually have a better prognosis. And this is what happens. They initially have a bump in their renal function. This happens with many therapies, not just with sacubitril/valsartan, and then it evens out. With the beta blocker, you have a transient worsening of their cardiac output, but then that evens out over time as well. So only in fairly extreme cases do you actually have to not or down titrate these. And as you can see here, whether or not they had that initial bump in the creatinine didn't make any difference according to the benefit of the drug, okay? So if they have a drop in their GFR when you start the medication, it's still going to give you the benefit down the road. Another thing that we love to do is we love to criticize others. So I like to do that. And so what happens is you bring a patient into your clinic, oh, they don't have them on this medication. Oh, they don't have them on that medication. And sure enough, sometimes it's because they weren't attempted on it, but often it's for very legitimate reasons. And it turns out that re-examining, so this is from the Qualify trial. This is an international quality of care for HFrEF therapy. You can see that actually fairly good reasons are given for most therapies. This is particularly true for older and established therapies. Where it falls down is with newer therapies. So the newer therapies, you can see that MRAs and some of the newer therapies, such as sinus node inhibitors, the newer vasodilators, these are the drugs that are more likely to not be used even after you've gone through the chart in detail, like they did in Montreal at their heart failure clinic here, and realized, yeah, you know, we could have used this drug and we don't have a good reason for not using it. So the older, more established drugs that are in everyone's repertoire, ACE inhibitors, beta blockers, they were very, very highly used, very few instances of non-consideration, as I would like to say, and true underuse. And then it's really the newer medications, the less commonly used medications where that gap still remains and where we need to think. So when you're thinking outside the box, keep that in mind, that the people use drugs that they know more fulsomely, and that's not a surprise. Don't expect to keep banging your head against the wall and finally get through. I've heard a lot of people say, well, yeah, I tried for 6 months and I finally got them on the beta blocker. Well, okay, that might happen in one patient every once in a while, but generally speaking, that's not what happens. This is data from the guided trial. This is the NIH-sponsored heart failure. You know, people like Kristen and Omid were in the trial, really good at using these drugs. And look, it's just a gong show trying to figure out what happens with the dose levels here. And at the end of the day, look at the left side, look at the right side. Is there much difference? A little bit. All that work for like 5% difference in dose, okay? So yeah, you can make advances and you should. And of course, following up the patient closely is needed anyway. But don't for a second think that you're gonna revolutionize most people's care simply by trying over and over again. At the end of the day, move on, move into newer therapies. How do we do that? Well, we can divide patients into several groups. One of them is to do patient profiling. And we tailor medical therapy. This was written a couple of years ago by the Heart Failure Association. And they did the same thing that a lot of other groups did. They have, on the left, you see clusters of physiologic parameters, blood pressures, heart rates, rhythm, and kidney disease. Those are the four things you look at when, potassium's not listed here, but it's really in the CKD part. These are the things that will guide what you can do with your drugs in almost every instance. But one thing that they always put, little orphan on the side, is the volume stats, and they never truly integrate the diuretics. So when they come and show you what to do in each of their different, and they had 11 different settings here, if you wanted to memorize them, they really didn't say much about the diuretics. So we're not a lot further apart. So these are the common mistakes that I see, that I make, that others make, that I see when patients are referred to me. There are little tricks that we learn early on in the heart failure clinics, things like separating out drugs and making sure they're not too dry. And I would say the top three things of reviewing why a patient can't tolerate a drug is make sure they're not too dry, okay? Make sure they're not too dry. And for God's sake, make sure they're not too dry. Those are the three things that you need to know in order to be able to titrate your medications. Happens all the time. If you have a busy clinical practice, and some of our outpatient cardiologists, they can't see patients every week. And so imagine, it can take, and we've done surveys back in 2015, that the average heart failure clinic in Canada takes close to a year to get to what they would consider optimal medical therapy. So projections based on clinical trials suggest anywhere between 4 and 8% chance of that patient suffering a death or a hospitalization while waiting to get to their optimal therapy. But we need to do better. So how can we do better? Well, one thing is to combine these concepts and to be much more aggressive. Do it in hospital. Make sure that, and the problem is people continually object and say, no, that's not safe, Jonathan. No, you can't do that. But I'm going to challenge that. And I say, yeah, you can actually. If you're willing to accept a 10% adverse event rate, That's what we've got in our data now. 10% adverse event rate. So 90% of your patients won't feel a thing. They'll actually get better. 10% of them will have some kind of an adverse event rate. Okay. And so if you use, there could be, I don't know, there's 30 different algorithms out there now published. Some people will tell you, Greg Fonner, he'll say, start all 4 drugs in the same day. Okay. And he gets a lot of pushback from that. Here's an algorithm that we've been using in one of our clinics here in Calgary. Called our cluster scheme because I couldn't think of anything better. If you come up with a better name, we might give you credit for it, depending on how good the name is. And all we did is we did a few things. One is we understood that multiple titration would be important. So we've divided it into 3 groups because 3 is a cool number. And it's also enables you to put 2 classes of drugs in the same group. And then we divided them according to how they affect the patient in terms of side effects, not in terms of their efficacy, because these drugs all work synergistically. That's been well proven. So it's really about how to use them that matters the most to the clinician. So on the left, you have drugs that have most impact on volume when you first use them, SGLTs and diuretics. In the middle, drugs that have renal effects, potassium and creatinine in the middle with a little bit of blood pressure. And then on the right, rate, rhythm, and a little bit of blood pressure, particularly. And then you have, one of them is preferred. So what's preferred on the left? Well, it's the SGLT. What's preferred in the middle? It's the ARNI. What's preferred on the right? It's the beta block. So all things being equal, those are your preferred. And then you use other drugs if necessary, or alternate back and forth. And if you do this, you can get them on all 4 main therapies by the time they're from hospital. Plus, you're not going to inadvertently delay introduction of GDMT and other helpful therapies afterwards. So what does it mean? It means because there's 3 clusters, depending on the patient's presentation, you can make up to 3 changes per visit. Don't wait too long. Not all visits need to be in person. Most of this titration, if the patient's doing well, for 90% of your patients, you should be able to titrate them on the phone. For the 10% that have an adverse event rate, you may need to bring them in. And the ones that have the adverse events, they're the ones that you need to move on them, and they're the ones that you need to personalize with. So we use these, and so these are the 4 criteria: whether they're frail and dry, their blood pressure, their heart rate, and their GFR. So these are all very easily available from all electronic medical records except for the volume. And if these are all satisfied, then it means that it's highly likely that your patient is going to tolerate a change in all 3 if indicated. And if they have less than those, then you'll only be able to change 1 or 2, sometimes even 0. And of course, the one that you don't necessarily want to titrate on that visit is the one that's dictated by the physiologic parameter that's affected by that. For example, if their heart rate's 55, you're probably not going to add ivabradine or change their beta block. All right. If their potassium's 5.9, probably not going to add the MRA, so on and so forth. So what does that mean? Well, we've got a clinic. We've been using this algorithm, and one of our fellows, Jordan Gibson, presented this at the ACC. This is very preliminary. It's preliminary in that we've got actually about 500 patients of data. But this is what has been cleaned, reviewed, collated, and reported. So we actually have a much bigger sample size than this. And you can see that out of 113 patients, it turns out that in 113 patients, we make about between 1 and 2 changes per visit. That's what we average. That's what we average. Okay. We don't average 1 or less. We actually average between 1 and 2 visits. 90% of the time it's tolerated, very few adverse event reported, and very, very good outcomes. And these are the kinds of changes that we make. On the left, it's mostly changing ACE or ARB to an ARNI. And on the right, it's mostly diuretic changes. And then there are fewer changes in some of the other medications. Notice the MRAs are kind of in the middle, and beta blockers are not ignored. It's actually a sizable chunk of visits where they are monitored or they are managed. I'm going to skip that slide because it's kind of busy. Take my word for it that we have significant improvement, and there's actually something called a composite score that you're going to hear about in the future that is associated with outcomes, and patients who are on a higher composite score, scores can go up to 14. You get 0 points for not being on the drug, 1 point for being on less than 50% of the maximum dose, or tolerated dose, and 2 points for being on more than 50% of the maximal or tolerated dose. And depending on how many therapies they're eligible for, that particular patient might have a max score of 4 or 8 or 12 or even 14. And if they're eligible for all of them, then you divide their score into 14 to get a fractional number. So the score is actually, described as a fraction. So that way you can control for some people who could be on 4 different drugs, another person who's only eligible for 2 drugs. You still get the same ability to use that fraction. It can all be good. So when you get there, now what? And this is where the real personalization begins. I know there's been some personalization that you have to do in order to get them on their GDMT. But what happens after that? And patients, as you know, even though they're on the big 4, they still get hospitalized. They still have complications. Some of them still succumb. So there's a next level. This is where we come in. This is where you and I, and it's a lot harder to do. It requires more care. It requires sometimes more frequent follow-up. And sometimes there's no right answer. I'm going to show you a few cases, and I'll tell you what we did to some of these people, and then you'll probably throw me out of the room. So one of the things that we can do is we can use digoxin. It's been unfairly maligned, in my opinion, very effective at improving symptoms. Our pediatric colleagues still use it quite a bit. They're kind of smart. And there are situations where it can really have a tremendous benefit. And if the key with digoxin is to not use too much, it's just like titrating GDMT. Don't do it when the patient's dry. With dig, don't let their level get too high. If it's not too high, it's okay if their level's low. I've done many levels. It's less than 0.6. I don't care. They're still on a daily dose. They're still taking it, and they feel better. So dig is a really useful drug, especially if they're in atrial fibrillation. Hydralazine nitrates are the alternative to RAS agents if the renal function does not allow. But in addition to that, in Black patients in particular, but also patients who have that unusual combination of advanced heart failure and enough blood pressure or enough vasoconstriction can actually tremendously, I mean, we've gotten people off of inotrope because of these drugs in our CCU. So it makes a huge difference, and they work quickly. You would get your answer within 24 hours when you start these drugs. You don't have to wait 3 months to find out if it's any better. Not like a beta blocker. And you can see on the right, you can see that trial actually had to be stopped early. That was exclusively a North American, self-declared Black patients. How you got into that trial. Don't forget to use drugs that slow their heart rate. It turns out that there's something that happens in a patient with low ejection fraction. Their LV function actually deteriorates when the heart rate goes up. It actually gets worse. So that doesn't happen to a normal heart. A normal heart, you get the force frequency relationship, and it gets better. Okay, EF is 50%. You jazz up their heart rate to 140 with pacing, their ejection fraction goes up. The opposite happens for the patient who has low ejection fraction. And this is particularly true for heart rates over 100, but in the longer term, it's true for patients with heart rates over 70 to 80. So in Canada, we approve this drug for heart rates greater than 77, but our guidelines follow a 12-year-old trial for heart rates over 70. The trick is lowering the heart rate is particularly useful when they're in sinus. It's not so clear what to do when they're in atrial fib. Don't understand why. And we have EP people in the room who can vouch for that. But using a drug to lower the heart rate that doesn't respond right to beta blocker, or who can't take beta blockers for patients in sinus rhythm, actually can have a mortality benefit. Using potassium binders can actually keep people on MRAs, substantially higher rates. This is a large randomized diamond trial showing that there were clear advantages of keeping people on medical therapy, even if they had hyperkalemia. This was a fairly expensive daily used potassium binder. As you know, using Kexlate is difficult. I know that's the trade name. I just committed a boo-boo there. Sorry about that. But the not well tolerated. These other newer ones, there's 2 of them out there. They're very, very well tolerated. The trouble is getting access to them. And that's the big challenge. Our nephrology colleagues are pretty good at getting access to these drugs. So let's go through a couple of cases, and then I'll talk a little bit about our EMR. So this is a person I've changed some of his details, okay? This guy had an MI. He's pretty young. He had a big myocardial infarction, and he just didn't do very well. Wasn't walking around, didn't feel good, and had a very fast heart rate, EF quite low, had an LV thrombus, and he grumbled and came in and out of hospital a few times. His main symptom was actually failure to thrive. And as you can see here, he had a borderline lactate. He was quite sick, and he was on whatever could be tolerant. He could actually tolerate. He wasn't on excellent GDMT. So we see this quite often. These are the kinds of people we're asked to see. And so what did we do? Well, we did a whole lot of things with this guy, and it turns out that he truly did have end-stage heart failure. But for a time, we actually made a big improvement. So he did get better when we slowed his heart rate down. He did get better with Digoxin. It wasn't perfect, but it did make a significant difference. And I can tell you, for every case like this, where ultimately he ended up on inotropes, because he would rally and then he would get worse, and then he would rally and then he would get worse. There's many other patients, particularly those whose hearts were not dilated, had low ejection fraction and a very fast heart rate. If you slow that heart rate down by any means that you can, and it's often that you can't use a beta blocker because they don't tolerate it. They get hypotensive or they get fatigued. And if you use other means such as Digoxin or Ivabradine to lower their heart rate, they actually get much better. Some of them slow their heart rate down to the point where their hemodynamics improve, their heart function improves, then you can get them on their beta blocker. I've done that many times. This even on Milrinol, lowering the heart rate makes a difference, and actually published reports of that. So that made a big difference. The other difference was in people who are volume loaded with really limited hemodynamics, don't run down the hill, walk down the hill. Diurese them much more slowly. I can't tell you how important it is in a borderline person that you need to slow their heart, reduce their volume gradually. If they lose 2 or 3 kilograms, a lot of people come into the floor the next day and say, yes, my guy lost 3.5 kilograms. And I'm thinking, no, he lost 3.5 kilograms. Now we have to wait for the potassium and the sodium and the creatinine problem to raise its ugly head and slow us down. So in these borderline individuals, the more tricky they are, the more patient you have to be. So 0.5 to 1 kilogram a day is the most I'm ever going to go in some of these really sick people, particularly in the units. Combinations of diuretics make a huge difference. Severely alkalotic individuals, because you're using single agent furosemide, respond quite well to drugs like acetazolamide to acidify the blood again. It makes a big difference. And especially if they're a bit of a hypoventilator, you don't want them getting too alkalotic, because alkalosis is bad for the heart, just like acidosis is. Sides of the same coin. Sometimes people don't do what you want them to do. And one thing that we've been reluctant to do is to find out for sure what the hemodynamics are, because you'd be surprised in some series post-MI, up to 10% to 15% of people who have cardiogenic shock in acute MI actually are dry. Put this one, we've had transfers from other hospitals come in on 1 or 2 inotropes up in our CCU, put in the Swan. They're difficult to assess because they're quite sick. Lead was 9, lead was 8. A little bit of fluid, cut back some of their diuretics. All of a sudden, they're not in shock anymore. We've all seen that. We see that quite often in the heart, on the heart service. I don't know, probably once a month. We see somebody like that, maybe once every 2 weeks, something like that. And then, of course, sometimes you have to use the inotrope. Just make sure they're not dry when you do that. So second case, this is a lady. These are all recent cases, by the way. So Kristen and Omid aren't allowed to talk about them because they know the patients. Here's another case that I wanted to illustrate. This is somebody who had came in with Graves' disease. These are difficult patients. Graves' disease, rapid atrial fibrillation, low ejection fraction. And notice that her heart's not dilated, 50 millimeters. BAE means biatrial enlargement, by the way, mitral regurgitation, pulmonary hypertension, and she very fast heart rates. Those were resting heart rates, by the way, not exercise heart rates. And her main symptom was fatigue. And it turned out with this lady that the JVP can sometimes mislead you in people with rapid atrial fib. You will often think it's higher than it really is. It'll often look like they're more volume loaded. And sure enough, that is what she looked like. And she ultimately was over diuresed at one point. And that made it more difficult because her heart rate became more difficult to control. See the drugs that she was on the right side. And the trick with this lady here was The heart rate wasn't dilated. So she's going to tolerate that fast heart rate very badly. She's going to tolerate aggressive vasodilators not well. So the rule of thumb is the smaller the heart is, the more tricky it's going to be vasodilating. Okay, because they can't change their volume easily. That's why. Okay? People with big hearts of EF of 20%, you'd be surprised at how much variation, what a long landing point in filling pressures they have in the volume. People with small hearts, diastolic, hard, stiff hearts, you'd be surprised at how narrow that window is of volume. Very surprised. So this lady's in the second part. So she had to be diuresed more slowly. She actually had to be given fluid because she was over diuresed, and she needed her heart rate controlled. Now, some people would have used amiodarone. In fact, most of you probably would have used amiodarone. In this case, she was placed on Nadolol, and I've never had a patient not have her heart rate controlled on Nadolol. So, you might have seen where it didn't, but I'm telling you, that drug is like, it's like the major leagues of heart rate control beta block. And metoprolol is like Pee-wee double A compared to it, just so you know. Pee-wee double A, metoprolol, Nadolol, okay? Just in case you're wondering. It's an unwieldy drug to use, however. Yeah, they get a lot of fatigue. Fatigue can be your limiting factor, but once you get their heart rate controlled, you have freedom to do other things. That's the key, right? So yes, I've transitioned them off to other things once their heart rate was under better control down the road. Yeah, that is true. That is true. It's a big major league drug for major league breathing. This is another person who presented after heart surgery. He had aortic insufficiency but pulmonary hypertension. And as you can see here, very soft blood pressure, decreased breath sounds at his right base. He had an AKI following surgery. And you're thinking, geez, what are you going to do with this guy? Because he's got no blood pressure. He's got an okay LV, but his right ventricle was basically immobile. And these are the hardest ones to take care of, in my opinion, the right ventricles. Sometimes the only thing you can do is wait it out, especially post-surgery. But there are other things that you can do, okay? So one, again, how to diurese them. Don't do it too quickly. You're going to regret it with this guy. Secondly, optimize their lungs, because the lungs will affect their right ventricular performance. We've learned this the hard way through our LVADs, because with an LVAD, you support the left ventricle, but the right ventricle still has to do its job. And in some ways, you actually make it more difficult in the short term with an LVAD on the right ventricle. So most of what we do is managing complications of an LVAD and managing right ventricular failure. That's what we do with our LVAD program. And so we've learned a lot of these things that the CVICU folks have known for quite a while, and we had to relearn them. Don't forget looking at their liver. A lot of these people will have occult liver disease that you don't know about. This is true for outpatients in particular. Make sure that they're not hypoventilating. Turns out that getting rid of things like pleural effusions makes a huge difference. Have a high index of suspicion for things like infected pleural effusions and infected lungs. But this is the kind of person you're going to have to go top to bottom and manage every single thing that you can. Try to keep them in sinus rhythm, make sure they're not over diuresed, make sure that they are diuresed enough. On the one hand, a high left ventricular filling pressure will make it worse on the right ventricle. On the other hand, hypotension will make it much worse on the right ventricle. And really understand what the pulmonary arterial vasomotor situation is like. Because if they have a low pulmonary resistance, the treatment is quite different than if they have a high pulmonary vascular resistance, because certain things like pulmonary vasodilators can make a difference. So these are difficult patients. They're very hard, and you end up having to do a lot of work. So that's some of the things that we go through that I thought you'd like. A couple of other tips. Iron deficiency. Patients feel better when they get their iron. They don't have to be anemic. Studies have shown improved exercise tolerance, improved quality of life, improved symptoms, and reduced hospitalizations for people who have their iron deficiency treated with intravenous iron, okay? So they don't have to be anemic to qualify. TSATs of under 20%, that's all you need. You can see that KCC, that's the quality of life score. Here's what's coming down the pipe, I think, for particularly patients with HFpEF, is relieving filling pressure through mechanical means. Turns out that the biggest area where blood is pooled in the body is actually in the in the belly. Okay, that's the big parking lot for blood. Splanchnic, the splanchnic circulation. So the splanchnic circulation, a lot of people, and you know, myself included, believe that one of the more important mechanisms by which people go into heart failure. Remember, more than 50% of people who present with acute heart failure don't have a weight gain. That means they redistribute the fluid, right? And they redistribute it from their parking lot, which is the splanchnic circulation. So if you can relax that, and in this case, you ablate the splanchnic nerve, you can either do it by an injection or here by a fancy new catheter. And studies have shown that these patients actually feel better. They have lower filling pressures, they have better functional class, they have a better quality of life score, they walk further. And this has been true, this has been shown for hospitalized as well as for outpatients. The big side effect of this is postural hypotension. So you can only do it on a unilateral basis. You can't, if you do it both sides, your patient's never going to get out of bed again. But if you do it in the unilateral, the rate of significant postural hypertension is only about 10%. This therapy is going to gain acceptance. I'm pretty confident of that. There's other ways that you can decompress the left side by creating an atrial shunt. We're involved in a study that's going to start later this year. I'm showing you this slide because it's more recent and it's a cool device that actually creates a fistula between the left atrium and the coronary sinus. So that'll scare some of you. But the complication rate was surprisingly low. And once again, you can see here, there are improvements in pressures, improvements in symptoms. And in particular, this kind of intervention works very, very well if the pulmonary resistance is not elevated. So this further underscores the importance in right-sided heart failure of understanding what the pulmonary resistance is. Because if your pulmonary resistance is high, offloading the left atrium is not going to really work for you. Pulmonary resistance is high, you have to deal with the pulmonary resistance. So there's going to be an increasing role for things like invasive human and animals. So that's personalization in a little bit of a nutshell. We have a few minutes left, I think. And I'll take the next maybe 10 minutes just to go through a few things that we've learned from larger. So this is the impersonal world part of it. We have Connect Care. The rest of the world calls it Epic, by the way. And this is a part of our lives. It's an electronic charting system, medical record system. It's an electronic order system, everything to all people. And you may feel that it's unwieldy, but there are some advantages to it. And I'll try to, this is from someone who loves to complain about Connect Care, by the way. And I just wanted to show you a few things and what we've learned from it. So here's what happens when you do an intervention based on previously published data. This is a study that looked at educating in hospital caregivers. This is from Hamilton. This is Harriet Van Spaal's group. And what they did is they had nurses to doctors to provide education for the hospital. Then they had a home visit or a nursing visit afterwards within 3 days, and to see if this had an impact on outcomes. Pretty disappointing, right? This was a stepped wedge. So they randomized the hospitals rather than the patients. Okay, that's a stepped wedge cluster model. What did we learn from this? Well, probably they didn't have a specific intervention in mind with those visits. There was no specific goal in mind. It was just, let's just see them. Will the fact that you put a bum in a seat in front of another bum in a seat days later, is that going to matter? Dr. Howlett's words, by the way. And the answer is not unless you have a plan. Not unless you have a plan. And there's other things too that might have conflicted that. I'm going to skip that slide. So what does it mean? It means if you're going to develop an intervention, particularly on a population level, you have to have a specific purpose, and it has to relate to one or more of these. It means you have to have the right therapy. You can personalize that. It has to be the right person. You can target that, or it has to be the right time or place. And this is we hear this mantra over and over and over again, but it actually does mean something. And the best is to have all three. So let's give some examples. This is from Yale. This is a cool trial. They use the same system we do, Epic. Okay. And what they did is they programmed Epic to go looking through tests And every time a clinician opened a chart where they had a low EF on the chart and they weren't on an ACE inhibitor, beta blocker, or MRA, the alert popped up, okay? And the alert says, your patient has low ejection fraction. Consider this. And it was a nice, nice little, it wasn't nasty. It wasn't like you're a bad doctor or you should die in fiery brimstone, nothing like that. It was, please do this. And look what they showed. The number needed to treat was like seven or eight, in order to get them on one more GDMT therapy with no increase in serious adverse events. That's all it was. It was repeated, it was targeted, and it was based on data. So these things do make a difference. They can change clinicians' behaviors. Here's another one. This was also, this is from Boston. And this is another group where they did two different things. They did two different types of interventions. The first was so they had one group where nothing happened. Another group where every time the chart was open, they got a fairly similar prompt. They were all cardiologists, by the way. Actually, no, that's not true. They were a cardiologist or intern. And then the other type was, it was just targeted to the clinician. Keep an eye out, and this only came out once a month. Keep an eye out for all your patients with low ejection fraction because you should use these drugs. So one was repeated every time, specific drug, specific patient, and the other one was general and less frequent, and hey, you better do this. Kind of like what we're doing today, right? Okay, so guess what happened? Well, what happened is on the bottom, you can see that there's a dose response here. That particularly with MRAs, because it turns out that beta blockers and ACE inhibitors, and they didn't really look at ARNIs in this one. Beta blockers and ACE inhibitors have been fairly stable usage-wise. They're saturated, they're older drugs. Like I said, it's the newer drugs where you see these big difference in usage rates. So they showed that the daily or the repeated, targeted, specific intervention worked much, much better than the general recommendation, which in turn was a little bit better than usual care. And it was of borderline significance, as you can see here, 0.11. So the general message. So basically, you can see this is a visual of the actual medication list that you see here. The alert is the daily one, and it's red, and it's much, much better than the periodic message. What about scores? So this is a complicated trial that I'm not going to explain in great detail just because of time. You could do a whole rounds on this. And so Jordan presented this at the Journal Club. He did a fantastic job, and I've stolen some of his slides as a result. I did ask. He probably felt obligated to give them to me, though. The pronged approach, but again, both very specific. The first prong was to use a validated score, in fact, two validated scores, while the patients were in eMERGE, to tell the clinician whether they were high risk, intermediate risk, or low risk. And it said, if they're high risk, you have to admit them. If they're intermediate risk, you're on your own to decide. And if they're low risk, you can send them home immediately or send them to a rapid assessment clinic and send them home. And if you do, you'll have our second intervention, which is we're going to see them within a few days in our rapid assessment. That's like the early HF clinic that we have here. Almost exactly the same model. And they had checklists, and they had specific criteria for entry and specific suggestions as to what to do when they got into the clinic, which is different than the PACT trial, which was just two bums and seats, right? What they showed was, number one, fewer high-risk people were discharged from hospital because they actually saw what the risk was. More lower-risk people were discharged. And they actually had a 2%, and in this world, in the quality improvement world, a 2% difference is huge. A 2% difference in the primary composite endpoint that came out to 6 months, and also that persisted to 1 year follow-up. Number needed to treat very small, less than 20 for this. So substantial improvement in outcomes. And the last trial I'm going to show you is something called the STRONG HF trial. This is a European trial. And these were patients who were just admitted to hospital with heart failure, didn't care what the EF was. whether they were on as long as they weren't on 100% of all their goal-directed therapies. And in this study came out before SGLT, so it's really just ACE, beta blocker, MRA. And if they weren't on full doses of all of those, they were randomized into the trial. Half of them went into what's called a high-intensity group, and the other one usual care. The high-intensity group, the first visit, they were put on 50% of all their drugs. In the second one, they made sure that they were on at least the lowest dose of all evidence-based drugs before they went home from hospital. And within 2 weeks, they were to be fully titrated. That's much more aggressive than what we do in any other jurisdiction. And sure enough, what we see is, if you look at the doses, and let's see, the bottom ones are the full doses, okay, the bottom parts of the bars, and the top are the lower doses. And you can see here that at baseline, they're quite similar, irrespective of whether it's the ACE on the left, the beta blockers in the middle, or the mineral corticoid receptors. But look what happens at visit 30 days and 6 months later. So these are early changes that are durable. They didn't have to walk them back. And in this trial, there was about a 10% adverse event rate. Okay, so very, very well tolerated, and significant reduction in death or hospitalization. In fact, this study was planned for 1,600 patients, and after 900 patients, it was stopped early by the data safety meeting. This is just a graphic for the clinic that we have. So it's very similar to that in the STRONG HF trial, where patients are supposed to be seen within 1 week of either discharge from hospital or discharge from eMERGE. Okay, so we have 1,800 discharges from hospital in Calgary region every year, and another 500 from emergencies, in case you wondered. So that's about 2,300 people every year. And according to the data we have, half of them, in fact, 45% of them are seen by family doctors within 7 days, and 55% of them aren't. And they're the group we're targeting. So there's over 1,100 patients that are potentially eligible. We don't have near the capacity to do that. We do the best we can. And that's what this clinic is for, is to see those people while they're awaiting either their heart failure clinic visit or their first family doctor visit. And that's where we took that cohort from Jordan's presentation that I showed you earlier. So if they have no early follow-up, they're seen in the heart failure clinic. So what did we learn? We learned that general, non-directed, non-specific interventions, infrequent interventions are less effective. Targeted, specific, personalized, repeated. That's what works in this business. We also learned that you can use very aggressive mechanisms to titrate medications, and you use this algorithm or that algorithm. We don't even know if there is a best algorithm. We're just using the one that we use, and so we'll know the data associated with it. And you can rapidly titrate them, and then you can get to that second stage where all the smart people, except for me, can make their therapies better. So the last little part I'll show you is that we've been using order sets here ever since 2009. Associated with the order set, this is Rob Miller, who did a really nice propensity analysis, and this is in keeping with the literature, folks. Reductions in 30-day death or hospitalization, very low numbers needed to treat. Well, this is like 38 variables, propensity analyzed, and 15,000 patients of data we got from SCN. And if you think that doesn't work anymore, I'm going to skip through these because these are all screenshots for the heart failure pathway. This is our data from Alberta before we went over to Connect Care. So people who were implementing the heart failure pathway that we've developed in the heart failure SCN, there was a 4% reduction in 90-day readmissions, no difference in mortality, and a much higher rate of appropriate referral and for patients to be seen in time. It did come at the expense of slightly increased emergency room visits, but not at the cost of a rehospitalization. So if you do a cost analysis on this, and you will actually show that it saves money to do this. And then once we got once we've looked at our now we're in Connect Care, this is what we see. People who use the order set in Connect Care, this is controlled not for 38 variables. It's just this is just a logistic regression. It's not propensity analyzed, and we're seeing about a 25% reduction in our important outcomes. with that. And it's, there's quite a few, as you can see, the numbers are like 5,000 now. So for a while. So basically useful is what I would say. So that's a bit of a long journey for you guys. Sorry for taking so long, but I thought it would be useful that you'd see what we're doing here. Some of the things that are coming down the pipe, what we're going to try to emphasize for heart failure care in Calgary and the rest of the province. And plus, when you talk for a long time, you don't have to answer as many questions. So I'm going to stop there, and if there's any comments or questions, I'd be happy to take them. Thanks for your attention. Well, I think what you're saying is, oh, sorry. So the question, thank you, forgot that. So the question was the issue of higher heart rates, people do worse. This is with low EF. And so the question is, does this also occur with conduction disease? Is there a difference? Haven't looked at it. We know that wide QRSs are bad for you in low EF. You know that very well. You treat that and you do it very well. Is there an added or amplifying effect of the wide QRS on the fast heart rate? Don't know the answer to that. Good question. You know what? We should look at that. Probably we could. Could you speak to the utility of tolvaptan in decompensated heart failure? So good question. Tolvaptan is a vasopressin inhibitor, works super well for hyponatremia. Absolutely, it turns out that the data for combining diuretics with furosemide, it doesn't matter whether you use chlorthalidone, hydrochlorothiazide, metolazone, acetazolamide, or tolvaptan. They all add approximately 2 to 3 liters of diuresis over the next 48 to 72 hours, in addition to compared to nothing. So they all work, and tolvaptan does too. Plus, it actually treats hyponatremia very well. The trick is getting it. It's extraordinarily difficult. Basically AHS has made it nearly impossible to get. And so even asking for it in hospital can be difficult, even more difficult. The only group that really has anything close to decent access is people with polycystic kidney disease, and that's the dedicated clinic in the nephrology group now. But it's a very expensive drug, admittedly. But certainly in these patients, by the time they get into this kind of situation for inpatients, they're expensive patients because they're using a lot of healthcare resources. So I simply don't understand why it's so difficult to get for those particular individuals, but it is. Works like a charm when you have it, though. Yeah, so her questions are getting harder and harder, aren't they? We're trying to maximize the uses of that. So it's my belief that that's a good use of specialized resources to get these people rapidly titrated. And the irony here is, if we use aggressive algorithms, it'll actually take less of our time to do. So, in fact, there's an email that was circulating around with Steve just a couple of days ago that you might be aware of, and we are going to look into trying to we tried to create a pathway for that within the hospital because that was lots of fun, and so there's challenges with that. Our continuity clinic is actually part of TCR at Repsol Center, so it's outside of the hospital, and that's much more flexible for us. So that's something that we're looking at. Yeah. Well, if the referrals are made, then they will not be refused. The question is, how quickly will they be seen, and what's the mix? Because there's already too many patients so what would we do? Will we go 3/4 people just discharged from hospital, 1/4 rapid titration consults? That's something we haven't sorted out yet. I don't want to speak for the whole group because it's, it may be that others will feel a different mix is most appropriate than what I do, because we're really guessing what the best mix of that is, what the best benefit is. so can we? Yes. So the question is, can we use Connect Care? And the answer is that people at Total Cardiology Rehab are not on Connect Care. Well, that's an interesting idea. So we'll take that offline. So would there be a forum through which people could communicate with the heart failure group to get advice? We don't have that in place right yet. We do have Specialist Link that is primarily for primary care providers, and we do answer those. The volume is not all that high. You're suggesting something slightly different, not unlike what that rapid email consult service that Sandeep was talking about. So not ready to speak for our whole group about that because they may have some important ideas. So we'll take that offline. I think it's a good question. Yeah. So that came from Kristen Lyons. Basically, what she said is that Co-op Pharmacies has a program where they actually can help counsel patients and help with titration and identifying opportunities for titration of patients, and it's proven to be quite responsive and helpful. Once you up the ante and give them more consults, you never know how they're going to respond to that. But certainly at the current volume, they do a good job. Kristen has also said that she has the contact for that, would be happy to answer that and any other heart failure question you may ever have in your career. Kristen Lyons, MD, at albertahealthservices.ca.
That note, we're top of the hour, so thank you very much, and hopefully we'll see you all next week.
Thanks very much, sir.